thank you all for coming. We're excited to have this walk and talk event today. So mainly today we're going to have some research updates, so probably some of you have already been speaking to Dave Adlam as we've walked around, and we've also got our new clinical research fellow here today, Dr Anju John. So we're going to just do a little bit about the work that's getting started there with our project. And I'm just going to start with a few little updates about some Beat SCAD activities that we've been doing over the last few months. So I just want to start with our website, really. This has been an enormous project for us. You may have seen that we launched a new website in February, and we decided that we wanted to invest some of the Beat SCAD funds to improve the website. So way up in 2015, when we launched the charity, Debbie created our first website. So Debbie's basically been our tech guru over the years, with building the website platform and maintaining it. And it served us really well over the years, but there was more we wanted to do with it, and it had some limitations with our own skills. And so we decided that we would invest in having a professional consultancy company come and help us with that project. So we're really, really pleased with the outcome. I hope that you've been using it. We really wanted to improve the overall user experience of the website, the navigation of it, and just bring in some streamlined activities. Some of the admin tasks that we were doing were very separate, so we've been able to streamline those in now, and it's reducing some of the admin efforts that we have within the team as well. So just want to say thank you particularly to Debbie, because Debbie led this project and invested a huge amount of time on top of her own day job. So, having meetings with the consultancy group in her lunch breaks and after work. They were a great company, a group called Ionic. They, were very flexible with us as a group of volunteers. They really made it a really enjoyable process to develop and, get the product that we wanted it to be. And like I said, Debbie spent a huge amount of time working on this project. And also Sarah, eagle-eye proofreader, picking up any little typos that might be there, hours of testing to make sure the navigation is spot on. She really thought about our different users, putting herself back into the shoes of being a new SCAD patient, and what information do I want to see on this website, where do I want to go. It really flows so much better than the previous website. So thank you so much to Debbie and Sarah. I think. So yeah, it was a huge project, and it has taken many hours over a number of months, but it's certainly worthwhile, and we're really pleased with it. And if there's anything you'd like to see on the website, please do let us know. We just want to try and make sure we're providing the information that the community need, and we love to have volunteers to help us to deliver those projects. And that might be your story. We have patient stories on the website. We want to kind of rotate them. What we've done now is to categorize them so that people can go onto the website and you can look for similar stories to your own, and you can also read about different stories just to sort of learn about the similarities and the differences across the SCAD community. So if you'd like to share your story with us, let us know. Similarly, if you've already got your story on there and you want to update it, I think that's a really important thing that we need to start doing, because I know my story that's on there I wrote 12 years ago, and when I read it now I don't know who that person is. I feel like it's a different time, a different mindset. I would write my story very, very differently now. So I kind of feel like an update would be really beneficial, because the progress that I've made, the person that I am now compared to then is quite different. So I think it's really important that we start to see that progress of stories over time. So yeah, we'd love to hear from you if you want to share your story. We have managed to do a few other activities on top of the website. So we've been seizing opportunities in terms of research and doing what we can to promote research. And we've been excited to see some new research projects getting underway in Scotland in particular. So those of you who came to the conference or have watched our videos, you may have seen that Professor Liz Newbeck and her team up at the Edinburgh Napier University have been starting to look into recovery from SCAD, so looking at in terms of physical and mental health. And we've shared a couple of survey links to their project. So I think just this past week we've shared one for a new survey. This is specifically for menopause, looking at menopausal symptoms and connect possible links with post-SCAD chest pain. So obviously they're looking for females and patients that do have post-SCAD chest pain as well as patients that don't. So, looking to compare that information. So, if you're interested in taking part in that, you can find the link to the survey on the Beat SCAD social channels. They did another survey as well, which was for fitness data. So patients who use the wearable devices that track heart rate, they want to collect data in relation to exercise that's done before a SCAD, at the, around the time after the SCAD, and then in the recovery period. So again, collecting information and just trying to find, anything that's sort of different within SCAD community, anything that helps to sort of further our understanding and knowledge of SCAD and the impact of SCAD as well. So it's really great that we're starting to see all of these other research projects going on, because we know the Leicester team are incredibly busy. They've been working for years now. There's lots of publications that have been coming out from Leicester and with the global efforts. So, we're hearing more about the genetics results that have been coming out from imaging studies, etc. So, it's nice that there are other groups that are also starting to look in some of the different areas as well. So thank you to any patients that have already taken part in any of these surveys, and thank you to anyone that's considering to do that. It's really important, and just keep gathering all this data, and it's really helping us to understand SCAD more, and particularly the impact of it, and how we can use that information to better support you. One other thing that we have been involved with, and I'll leave more of the details to Dave because I can't remember the details, but we have been supporting Dave where possible with some research applications and funding applications for some other research opportunities, and also trying to explore ways that we could potentially secure funding for specialist SCAD clinics. So that at the minute is a real kind of, it feels like a pipe dream sometimes, but we're trying to support Dave as much as we can to try to get more SCAD clinics underway. It's probably a good time to hand over, because I can't remember which of those projects we approved and we could talk quite publicly. So that's everything. I'll hand over to
Great, so thanks for the introduction. So when the Beat SCAD trustees talked about how we were going to do this, I offered the usual 3.5 hour with slides, full explanation of the latest stuff on SCAD, and they said they didn't want that. So you're going to get the 3.5 hours without slides. Okay. So I'm going to focus really just on talking a little bit about the research side of things. I'm very happy to talk about the clinical side of things, but there are lots of videos on the website that you can look at that have information about that. But do ask your clinically focused questions at the end, and we can sort of address those as well. But we'll talk a bit about the research side of things. So if our starting point is in terms of research, there are, if you like, the kind of what is this all about questions. What is SCAD? What causes SCAD? Why does SCAD happen? All of those kind of questions. And then there's a bunch of questions, I suppose, which are more about what should we do about it? And there are different strands of research that we and others are doing. And I think it's probably also really important to say that with SCAD research, as with anything that's not a kind of hugely common disease, SCAD, as we're finding, isn't rare. That's why I'm kind of lost the hair and all that stuff. But, it's less common. And one of the critical things in SCAD research is that partnership, both within the UK, with all of our cardiology colleagues here, with obviously our patients, that's you guys, you're critical, can't do research without you, but also internationally with our friends across the world, particularly our collaborators in the Mayo Clinic, but also France, Australia, Canada, all of these different groups, pretty much anybody who has a deeper level interest in SCAD, for example, contributed to that genetics paper that Bex was just alluding to. So everybody contributed their DNA from their patient populations. And I think that shows a lot about what SCAD research is about. It's a collaborative thing, often internationally, and we couldn't do it otherwise. And that's really, really, really important. So if we go to the whys, and that's sort of bit of the questions first of all, we talked a little bit about what we know about the genetics. So there's kind of two key findings from that are, first of all, that SCAD that runs in families because of a single gene that's gone wrong is very uncommon. That's something that seems to be associated with particular syndromes. So it's not a strongly familial condition. That's quite important and helpful for us to understand because it tells us about whether we should be testing everybody's genes or whether we should just be testing a small group of people's genes. So useful things. What we've then found is that we've looked at what we call the common genes, the common genetic variants. These are genes that we all have, but it's more about the flavour that SCAD patients have as opposed to somebody else. And what we've identified with all of those partners is 16 genes which confer risk of SCAD. And this has given us, if you like, an opportunity. It's opened up Pandora's box to say, well, what do those genes do? And how do those genes explain what happens in SCAD patients and what makes SCAD patients vulnerable? So it's a really key set of findings. We reckon that of those 16 genes that we've found so far is about a quarter of the total genes which confer risk in SCAD. So the important message here is that this is the start of a journey and not the end of it. And so one of the things that we are doing at the moment, and we will be doing in the future, is we are going to be hunting down all of those SCAD patients out there who haven't yet supplied a blood sample and are prepared and will consent to do so. And we can send out blood kits to wherever you are. You then have to flirt with your GP practice nurse to get them to take a blood sample, which you can then send back to us and we can get the DNA from that. And what we hope is that by doing that again, working with our international friends, is that we can get further down that list of genes to give us even more insight and understanding into that aspect of things. So one thing to look out for, one thing to think about, particularly if you were maybe in that pandemic group of SCAD patients where we couldn't take blood if you came to the clinic, for example, or if you just missed out for whatever reason, that's something that we'll be very interested in doing. So that whole genetics bit opens up one thing. So we know that genes are important. We want to know a bit more about that. The next thing is that we have to recognize, looking around the room, that SCAD is predominantly a female disease. That doesn't mean that men with SCAD are not important. They are very important from a research perspective because their hormones are not cycling and moving around. And so one of the things that one of our previous clinical fellows was focusing on was SCAD in men, and we may be doing some more of that to try and, if you like, understand a little bit about SCAD in that environment where those hormones aren't moving around. But we are clearly interested in how female sex hormones are involved in SCAD. It surely isn't a coincidence that SCAD is a condition that happens a little bit after pregnancy. You can see a beautiful picture over here sometimes, or in that perimenopause or premenstrually when the hormones are moving around or declining and so on. And we'd like to understand that aspect a bit more. And that's a particular focus of our research in the next bit, both in terms of looking and scanning people to try and understand how hormones might impact on how the arteries work, both women that are cycling, but also potentially women that are going on to HRT or coming off HRT. We would be interested in looking at those patients as well. And we'll also be doing some work, so as well as Anju's work, she'll talk a little bit about that in a moment or two. We also have a British Heart Foundation funded PhD student at the moment who's going to be doing the same kind of work, same kind of questions, but in the lab. So again, some of you will have maybe given a little skin biopsy sample, a little piece of skin, which enables us to grow up the cells in the lab that we can then do experiments on. So we can expose those cells to hormones, and then we can see what happens to them in terms of what do they express. Do they express particular genes? Do they produce particular bits of connective tissue or things like that that can help us to understand and answer things? So Rahul is going to be doing that little bit of work. So there's both a kind of understanding the hormones at the whole person level, yeah, and also breaking that back down towards the genes to try and understand how that all works. And one particular aspect that we are focused on is HRT, because we have a perimenopausal population, a large perimenopausal population. And we have wondered for a while about HRT. Is it beneficial? Is it harmful? Does it not make any difference? But also, does it potentially help if you have a lot of chest pain after SCAD? And some of you will be familiar with the fact, because you will have experienced the fact that many patients who have SCAD will experience quite a lot of symptoms afterwards. And anecdotally, for example, in women of childbearing age, we've noticed that if you have patients who get premenstrual chest pain, which we sometimes see, that taking a hormonal contraceptive, like a progesterone-based contraceptive, can help with that, can iron out the menstrual cycle and reduce the amount of chest pain patients experience. So we wonder whether HRT might help with the chest pain that patients experience after SCAD. So one of the things that we are doing as a first look into HRT and SCAD is to a randomised clinical trial where we're going to take patients who have chest pain after SCAD and randomise them to HRT or pretend HRT, so that you don't know what you're taking, we don't know what you're taking, but that's a good thing because it means that it doesn't bias you, it doesn't bias us. We can look at the end of it and try and understand. And what this will do is it will give us the first proper data on HRT and SCAD, so that we can start to really understand what's going on, both in terms of the kind of biology, the cells in the lab, the patient in the scanner, but also in terms of the symptoms and what that does to patients. So this is a big program of work across a number of different areas that we're particularly focused on. And some of you who will either be visiting the clinic in the coming months, and some of you who may be visiting because you've just watched the video and you're coming to the clinic in a little while, we may be approaching you to ask about participating in some of those things. We'll obviously always be looking for your DNA, maybe a little piece of skin, maybe you want to be part of the randomised clinical trial and try and help provide some data for us that way. So there's a whole bunch of things that we are going to be wanting to do to try and understand that angle. So we've got the genes, we've got the hormones, and we need to try and understand these kind of how these different elements work. Some of the other things we've been talking, I forget exactly who I was talking to it about. We were talking a bit about exercise. And exercise is another thing that people ask about, and there's a bit of uncertainty in SCAD. Is exercise good for you, like we think exercise is good for hearts, or actually is exercise a risk to patients who have SCAD? And there's uncertainty about this in terms of the literature. There's some suggestion that some people might have their SCAD at times of exercise. But of course we know lots of people are exercising. So maybe that's just bad luck. It happened at that time. So as you heard a little bit earlier, one of the things we're working very closely with our Scottish collaborative colleagues is we're going to be collecting data from patients' phones and wearables to try and work out what happens before SCAD, and questionnaires as well, just to collect a picture as to what people's exercise is like in the run-up to SCAD. How does that compare to normal people? Is it just the fact that there is a spectrum of patients with SCAD who are doing a spectrum of exercise? And actually it's the same as if we look at age and sex matched patients. So we want to collect that data, but we're also interested in that whole exercise rehabilitation piece. What happens afterwards? We know that when you have SCAD, you'll all know this, that you go from whatever exercise you were doing to nothing because you're sitting in hospital looking at me. And then after that, obviously what you want to do is we want you to get you back to where you were before as quickly and efficiently as possible. But we know that there's a spectrum of things, isn't there, amongst that? And there's a bunch of reasons why that is, including chest pain symptoms, consequences of your SCAD, and so on. And we want to try and understand that so that we can better tailor exercise rehabilitation strategies to patients who've had SCAD, rather than the sort of more generic things, because obviously rehabilitation is great, many of you will have done it, but a lot of the rehab programs, of course, are tailored to patients who have conventional heart attacks, so it's going to be those older chaps. I'm looking forward to getting to be one at some point. And so, but yeah, so you understand obviously that, you know, there are differences. There are even just fundamental differences between the sorts of exercise that women do to the sorts of exercise that men do. And we need to try and understand that so that we are delivering the right rehabilitation strategy to people. So there's a whole kind of exercise piece that we want to understand from the what's the relationship between exercise and SCAD at the beginning bit, through to the how can we try and help people to rehabilitate and recover better afterwards. That's going to involve us asking you to provide data from your wearables, from your phone that actually is logging what you're doing all the time. Did you know this? But it is, amazingly. And if you haven't switched it off, if you kind of look, it will give you all sorts of interesting information. But also we're going to be shipping out little accelerometer devices and wearables, maybe even Fitbits, to patients shortly after SCAD, and trying to collect data from that so that we can get a clear picture, but also so we can calibrate things. Because what we need to be able to do is to compare the research accelerometer data against your phone and against your wearable, so that we can take all of your different wearables and different phones that are recording slightly different things and calibrate them together using that, so that we can make you similar enough to be able to compare you. Bit complicated, but basically wear the stuff that we send you and give us the data back. Emotional stress is something that we've talked about. Again, a few people on the walk, we've talked a little bit about the impacts of emotional stress on SCAD. We know that there's a role of emotional stress. I always emphasize the fact that this is not a one-to-one relationship. It is not the fact that SCAD patients who have emotional stress immediately have SCADs all over the place. There's a lot of emotional stress, there's not a lot of SCAD. Always remember this. It's otherwise you end up with a situation where whenever something emotionally stressful, like giving a talk to a room full of people, happens, then you start getting more stress because you're thinking that stress is bad, and then you get even more stress because you're really stressed now, and then you just go up the spiral of stress into a very stressful place, and this isn't very helpful. But again, what we want to try and do is to understand a little bit more about this information, and particularly the impact of that on people's rehabilitation and recovery, and that's something that we're hoping to work with colleagues in Canada who have a background in psychology, which is not my background. I'm completely useless at psychology, although one of my daughters has done an A-level in it, so I keep getting asked questions where I'm like, but yeah, so because obviously these are key things. So that's a sort of a little bit of a spectrum of things that we're doing in the kind of why area that I called over here. And then we have the what to do about it area that I called it over here. In the what to do about it area, we have a number of things which are very kind of, you know, we're hopeful are going to progress. Clinical trials are at the heart of what will ultimately answer a lot of our questions. At the moment, we base a lot of what we do on observational data, where we look at people and see what happens. Beta blockers is one of those things that we talk about, control of blood pressure. There's bits of data that say that these are important things. But what we really need to be able to persuade the medical community and me and everybody else that what's a good treatment, what's not a good treatment, is clinical trials. The first clinical trial has started in Spain. So sometimes people say to me, oh, am I safe to go on holiday to Spain? I'm like, they know more about SCAD than I do. Spain, great place to have your SCAD. So a randomised trial has started in Spain. We are also hoping to participate in a large international clinical trial to try and answer the aspirin or not aspirin question in a bit more detail. We're waiting for a funding decision from the British Heart Foundation, we'll see, but hopefully that's being funded from all the different nations to try and support that. So that's the first little clinical trial. We talked about our own first little pilot clinical trial looking at HRT, and hopefully this is going to be the start of a series of clinical trials, both nationally and internationally, which will really firm up on the data, so that when you come to my clinic and I give you those wishy-washy answers about tablets where I go, I think you should be on this, I can actually say, no, there's pretty good data that this is a good thing for you to take, and this is why. So that's a kind of, another sort of pipeline thing about what's happening next. We're also working hard to try and understand better how we can improve the diagnostics of SCAD. We know at the moment that the diagnosis is based mostly on the invasive angiogram. CT-based diagnosis would be nice because it's non-invasive, but CT has a lower spatial resolution. It can't see small things. And so when SCAD happens in small vessels, it can be easy to miss with CT scans. And we have a PhD student who's actually supported by the RAF, who's working at the moment in London. Again, I'm kind of co-supervising him. And his focus is on, can we develop a non-invasive approach based on predominantly CT imaging, but potentially we'll also use some of Anju's work and previous work from MRI to develop a better way of looking at these non-invasive approaches to imaging. Now, there's a journey to go down there. We're not at the end of that road. But what we are starting to see is things that we can recognize that make SCAD patients a little bit different. So we know, for example, that after SCAD, an inflammatory response develops, which is part of the healing reaction. You know that the bruise heals, but as it heals, there's an inflammatory response outside the artery that supports that healing process. That inflammatory process can be detected by CT scans these days, but at the moment it's not used as part of the diagnostic process for SCAD. So we've been starting to look at that and to show that we can measure this inflammation in SCAD patients and that it's different from patients who have other types of heart attacks and other conditions. We also know that often, some of you will have heard me comment about it or others comment about the fact that the coronary arteries in SCAD patients are sometimes a little bit curlier than other patients that we see. And again, what this gives us is another little thing that if we can measure it and capture it, we might be able to sort of, if you like, give value added to a CT scan so that a radiologist, a clinician who's looking at it can go, okay, we've got curliness, we've got inflammation, maybe we've got some other features that we can pull out. Maybe we can use that artificial intelligence. AI is brilliant because when you've got a small brain like me, you can use the artificial one to help you out. But you have to recognize that AI, particularly from imaging, is a potential way of spotting things that even you can't see with your eyes. And so again, we'd like to see whether we can apply those kind of techniques to scans to see if we can get better diagnostics. And again, in parallel with that, we've got hopefully another PhD student we're just writing up where we might be able to do some more work looking at blood tests and things like that to see whether we can improve diagnostics. So SCAD research, you know, bearing in mind and remember where we began. And sometimes I put that slide up of me, about 5 of you, and Rajiv Galati, who came over to us from the Mayo Clinic to kind of get us supported and get us started here in the UK with our SCAD clinical and research program. And then look at where we are now, room full of fabulous faces, but also we've got this, if you like, sort of almost sea of research projects that if we can keep them going, keep them supported, that hopefully when we have this talk next time and the time after, we can say, okay, this is what we've learned. These are the extra things. This is the explanation as to why it happens. This is the set of tests we should be doing. And this is the treatment that we'd like to give you in order to kind of, protect your heart and reduce your risk. Now, we're not there yet, but we are quite a lot further down the road than we were when we began. So hopefully we can keep that up. I want to introduce a couple of people. This is just the first section of the 3 hours. Call it section 1A of 10. I want to introduce a couple of people to you so that you know who they are and a little bit about what they are doing. Jane, I'm just going to introduce, many of you will know already. So Jane and Jay and Jenny's not here, but the triple J's are basically, they're basically the engine behind SCAD, right? So without these amazing people, the SCAD clinic would cease to exist, SCAD research would not exist. I would have collapsed long ago and been dragged out by my boots into Bodsworth Field. So they are completely amazing people, but I wanted Jane just to talk a little bit about the process of research so that those of you who haven't come yet will understand a little bit about how it works, and also particularly those people who are not coming to one of the clinics that I run in Leicester, London and Scotland, but are going through another system, so that you understand how you can connect to the research. Jane, did you want to just say a quick few words?
So the research is obviously really important, and there's a couple of ways that you can get into the research. If you are referred to see Dr Adlam clinically, then we automatically know your name, and from that we can contact you directly about the research. But just because you're not seeing Dr Adlam clinically doesn't mean that you can't be involved. And the way you can get involved, if you go on the Beat SCAD website, there is a link, and that will take you to a registration portal where you can enter your details. And then that comes through to us at Glenfield, and from that we can send out a consent form. And that consent form enables you to join the SCAD UK registry. And basically, that consent form, you're just saying that yes, you're happy to be contacted, and we can enter your details and we can look at your details and your information that you've gathered from your clinical journey. So once we've got that consent form back, because we can't do anything without it, what we'll do then is we'll email you and ask you for further details about the hospital that you were diagnosed at or the hospital you're being treated at. And the reason we do that is even if we're not seeing you clinically, we are then allowed to request copies of your angiograms or your scans, of any results you've had, blood test results or anything, and we can collect that and get a full picture of you. And then once we've got that, we can then contact you again as part of the UK registry to request a blood sample. So the blood sample that Dr Adlam was talking about, it doesn't mean if you live in Southampton you have to travel to Leicester. We can send that kit out to you. You go to your GP, have the blood took, post it back to us, you get the special box and all the kit, and we can process it in the same way as we can somebody that we've seen in clinic. So that's the first step, and the UK registry is really, really important, and we now have over 3,500 people on that registry. And that's a mixture of patients, family members and healthy volunteers. So anybody out there who has friends or family that want to take part to support you, or just because they want to take part, brilliant, they can register in the same way.
I'm going to interrupt because I'm really rude, just to emphasise that. So one of the things that we've talked about a little bit about the genetics, so one of the things that Rahul is doing is he's going to be interested in some families that he's going to have a look at. So if you get contacted, then make friends with your families again, is the answer. Your lovely families, see if they would give us a blood test. So it won't necessarily be anybody, but just be aware that you might be contacted about that. The other thing is that in the world of SCAD research, healthy volunteers are crucial, because we can measure anything that we like in SCAD patients, but unless we have somebody who is essentially the same age, gender kind of thing, who is healthy to compare it with, we don't know whether what we're looking at is normal or abnormal. So unfortunately, I have very few friends because I spend such a lot of time doing SCAD. So I'm certainly running out of my female friends of the appropriate age. I kind of walk into a room and they run. I think so it's worth having a think about it. You know, the phone a friend, bring a friend. Again, helps us to provide those critical comparisons. So if you've got a friend who's interested, might want to go through an MRI scanner. If it's one of our studies, then let us know. Sorry.
So that's the UK registry. So like I said, that allows us to look at information. It allows us to speak to you on the phone to gather information, for you to fill in surveys and things we may send you, and it also allows us to do that blood sample. Research is completely voluntary, so it doesn't affect your clinical care in any way if you choose not to take part, but if you do and you want to do the UK registry, it's so important and we're very grateful for it. There's also another registry, which is called the European registry, and this is exactly the same. You don't have to do anything, you're just allowing us to look at imaging, gather all that information, but we're actually in multiple countries now, as far as Dubai, New Zealand, as well as all the European countries, and it's looking at the same kind of data but on a much bigger scale, which obviously then gives us much more information. You don't have to do anything, we're doing it in the background, but we can't do it without that additional consent. The third part of the research is what we call the full study, the phenotyping study. Could potentially involve a further visit. And if you consent to that study, it means that we can look at more things in your blood, so not just the genetic biomarkers, but we can do sequencing, etc. And it also means that we can do the scans and the ultrasounds and the skin biopsies and other things that Dave has spoken about. And again, you can choose to do all research, no research, or just some of it. So if you're on the UK registry and you want to be on the phenotyping study, brilliant. If you just want to be on the registry, brilliant. With the full study, you may or may not be asked to come for a visit. And the reason I say you may or may not be asked is nobody is more or less important, but you're literally with us for a day. And it's quite a busy day, and potentially a lot of things could be done to you, and the amount of data we get is massive. So we only look at smaller subgroups at any one time, i.e. Anju wants to be looking at ladies of childbearing age that are not on any hormonal contraception. So we can then look at that database of people that have consented, because we're allowed to look for that information, and then we can invite that select subgroup to come and see us, can analyse the data, and we're led by the research. So we may look at 30 patients, look at the analysis, think actually, let's veer off that way a bit, or we're on the right path. It doesn't mean that anybody's more or less important, everybody's important, but that's why some people say, well, I registered for the research and I've not been invited, but that's why. So it might be 3 months or it might be 3 years. What we try and do, or we're trying to do, is to speak to everybody at least once a year. And that's just to check that people are okay, to touch base, but importantly, how have you been? Have you had any further imaging? Because very often patients will see Dr Adlam initially, but then they'll still have their follow-ups in Ipswich or Southampton or Manchester because of the travelling. And that's fine, but then if you say, oh yes, I've now had an MRI scan, because you've consented, it means that we can request those scans. But the only way we would know is by speaking to you. But at the same time, we're available and people can contact us at any point as well. So like I say, research is completely voluntary, but we'd be really grateful for anybody, patients, family, friends that are willing to help us. The more information we can get, the better.
Thanks, Jane. The point is that there's loads of ways, there's loads of bits, there's lots of stuff going on. We should also say that we're very grateful to everybody who has contributed in all sorts of ways. So, you know, those people that have signed up to the registry, you know, haven't necessarily known, but the pilot CT, the work that we've done already, that Charles, who's working on that I mentioned a little earlier, will have been done on CT scans that, you know, people have signed up to the registry and said it's okay to use your scans, and then so off we go and we do that analysis. So you won't even necessarily know that we've done it. But you know, because you've given us your permission to do that, it's enabled that really important piece of research to be started. So the next person I wanted to introduce before I go on to the second hour and a half of my talk is Anju John. Anju's just going to tell you a little bit about what she's doing. So she's getting started.
Yeah. Hi everybody, my name is Anju and I'm the new research clinical fellow. So it's been like 4 months since I've started. I've seen a few of you in the clinics, but I've been spending most of my time in setting up the new project and making a few changes to the protocol and getting myself trained as well. So I'm just going to give you a summary of what we want to do and why we want to do it. Now, SCAD, as we know, is more common in females, and there's also a peak incidence like in the menopausal period and also like postpartum and premenstrual period. So we always think that there is an association with sex hormones and SCAD, and this is one of the main reasons why I want to do this project, looking at sex hormones and its association with SCAD. And also, we're always motivated by patient-led research, and the main questions that were raised were about post-SCAD chest pain and also about the safety and efficacy of HRT in postmenopausal women. Post-SCAD chest pain is very common, leads to multiple hospital admissions, and it also has a significant impact on the quality of life as well. So I believe that this project that I do would add some light to the use of HRT in managing post-SCAD chest pain. And the other is about the safety and efficacy of HRT in postmenopausal women. So some clinicians, because there's a female sex preponderance, try to stay away from using HRT in menopausal women, although there's no good quality data on it. So hopefully this project would add some light to it, and we'd know if it is safe or if it is useful in managing chest pain. I just wanted to thank Beat SCAD for their continued ongoing support and for funding most of my projects and my salary. So thank you.
So as you can gather, we're very excited because Anju is completely brilliant, and I'm looking forward to going on a prolonged holiday for the next few years while she does all of the hard work. And thanks also to Martin, who kept going, the microphone like this. And I was thinking, gosh, you know, what if is a bit of my lunch down here, or what have I done? You know. Right, so I am going to pause at that point, just because 4 or 5 people at the back have fallen asleep now, and because I know that there's probably a few questions out there. I think there were some questions that were kind of collected up in advance as well. So maybe we start with an advanced one, but stick your mauler in the air if you've got a question, and I will do my best to answer it.
Okay, I'll start with one of the pre-asked questions. We recently had our first example of SCAD in female identical twins in the SCAD community. They had their SCADs 9 months apart. Does sharing genetic material make an identical twin more likely to have a SCAD themselves if their sibling has already done so?
So a great question. I'm not going to talk about the individual cases, I think, that are referred to there, but just a general question about the genetics. So we've covered a bit of this, which is to say that, importantly, SCAD is not something that generally runs in families. This is something that our friends at the Mayo Clinic showed some years back. The reason is that although genes are important in SCAD, and they are important, they do have an impact, those single genes that run through a family are rather uncommon, and they're generally associated with other syndromes. So things like adult polycystic kidney disease was one of the genes that came up when we looked at this study. So that's a condition that causes, obviously, cysts in your kidneys. No genius is there. And obviously there will be some patients out there who do have these syndromes, and we will look after those patients as well, and we're very interested in those patients as well. So if you're in that group where you do have a connective tissue disorder, or you do have one of those relevant cases, we may be in contact with you and your family to try and understand what happens there that meant that you got not just adult polycystic kidney disease, but also SCAD. So how did that work? Because again, that can provide us with some insights. But remember that most patients with SCAD don't fall into that category. That's only 3 or 4% of the total. So 97 out of 100 patients are not in that group. For most patients, it's to do with those many, many genes, and it's the flavour of those genes. I sometimes say it's the genes that make you you, and because we wouldn't want to make you anybody else because you're all marvellous, right? We don't want to change those genes, but what they do is they give us an understanding, because they tell us where to start asking questions about what makes patients who've had SCAD vulnerable. And obviously if we can understand that, then we can start potentially thinking of ways to have an impact on that. So the specific scenario of identical twins is obviously an interesting one, something that we would definitely be interested in as part of the study, and those very few patients who do have SCAD or some similar condition in the family. And as I said earlier, there will be some families that we will be in contact with in the coming months to say, you know, can you get your mum, your sister, your cousin to, you know, maybe sign up to the study and give us a blood sample as well, because that helps us, because then we can see whether it's the many genes that are moving through the family, or whether there's another particular gene, or to understand how all of those genes interact, because obviously our genes is a big and complex picture, and we need to try and build it to understand more clearly how it works, because obviously there may be genes that are protective as well as genes that confer risk, and if we can understand those things, that maybe gives us some, again, routes to think about in terms of future strategies for treatments. Yeah, go for it. Yeah, go, Martin.
What percentage of patients are male versus female?
So it obviously varies a little bit depending on the studies, but it's a very highly female sex predominant condition, up to 90%, 80 to 90%, something like that. And I guess that is probably more remarkable than it feels at first when you think about it. But this is a vascular disease. This has nothing to do with things that are specific to women, for example. And it is pretty much impossible to think of another disease, well, it is impossible, I can't think of another disease, that doesn't involve things which are specific to women, that has a nearly 90% or 80 to 90% female sex predominance. And that's the reason that we've kind of focused some of our research interests in this area, because the genes that have come up so far, whilst there's some interesting connections to sex hormones potentially that we're looking into, they're not like obviously connected with sex hormones, which suggests that maybe the sex hormones are maybe an independent risk factor that's working in a different way. So, you know, we're interested to see how the genes and the sex hormones interact to confer risk of SCAD. So actually, you know, quite a bit of answer from both the two questions. If we can understand how all of those things intersect, then, you know, we're hopefully onto something. Of course, the other thing with understanding sex hormones is that, as we all know, there's a whole bunch of things out there already that can modify sex hormones. You know, there's contraceptives, there's HRT, there's medications which can block sex hormones in terms of treatments that already exist for breast cancer. So part of the reason that it's important to try and understand that is that it's a very manipulable system. And so if we can understand how it works, maybe we can understand what's better in terms of patients' risk, and that we can modify things favourably in that direction with treatments that are already out there. Because we all know that developing, you know, Dave's amazing SCAD medicine, you know, from scratch, that's a completely different thing, will be hugely expensive and, you know, take 100 years. And, you know, I'll probably have fallen off my perch by then. Whereas if we can use something that already exists, repurpose things by understanding how things work, it's much more likely that we'll get to something that's useful faster. Yeah, go for it.
Talking about exercise post-SCAD, is it because we don't know, compared to a conventional heart attack, that we worry about getting into exercise, or is it because we do know that something very different to the conventional heart attack? Because I mean, I had a conventional heart attack and they had me walking around rooms very fast, almost immediately.
Yeah, so the challenge with SCAD is that there is reported in the observational studies an association between exercise and SCAD. We've known for a while that there are potentially a few, particularly male SCADs, who have their event at the time of weightlifting, so isometric exercise, or doing extreme exercise, running up the side of a mountain or something like that. So that's kind of created some kind of disquiet and some anxiety about how safe exercise is in SCAD. But we have to remember that these are kind of observations. Do you remember earlier I was saying that it's all very well me taking lots of images of SCAD patients, but if I have no healthy volunteers to compare them to, I don't know whether what I'm seeing is normal or abnormal. And it's a little bit the same here. Just because we observe that SCAD patients have their events in association with exercise, but you're a young population. There are going to be people out there who are doing exercise. So is it in fact just that, you know, younger people exercise? Or is it that exercise is involved in determining some aspect of the risk of SCAD? Or is it something completely different, which is those genes that I was talking about before, which we know are to do with the glue that holds cells together, adhesion proteins and the connective tissue? Is it that those genes just make you a little bit different so that some SCAD patients find exercise a bit easier? I know that I don't have those genes, but anyway. So I think that there is some unknowns here. What I can say is that Anju's predecessor, this is work that we are hoping to develop further on. We've done some work on basically maximally exercising patients after SCAD, including men, patients who have recurrent SCAD. And I can tell you that that was entirely safe. So we don't have any problems with putting people onto a treadmill to maximum exercise. So that provides some reassurance. Obviously, we need to build on that data to kind of build on the level of reassurance that that kind of provides. But what we're hoping to do from the exercise, as well as build on that pilot data, is to understand how other aspects impact that recovery. So we've talked a little bit about post-SCAD chest pain. We know that that's a really important and troubling symptom for many, many patients. And of course that affects your recovery and rehabilitation. Because if you're getting a lot of symptoms, you're not going to rehabilitate and get back to your levels of exercise. So there's a whole bunch of questions around this area. For the time being, we have very simple guidance. It's on the website for patients that exercise. And that is that we recommend against lifting weights or adopting stress positions. That's your 10-minute plank that you all do. Yeah, no. But it's those stress positions as well, yoga positions, that you can't maintain whilst breathing normally and steadily. We're trying to avoid what's called the Valsalva maneuver, where you have to strain and lift something. Or when you're doing that 10-minute plank that you do, that there's a time that happens where you can't hold your breath anymore. You know what I mean? When that happens, we would like you to stop. You can then go again, you know, after you've had a little rest, as long as you're breathing freely. That's the idea. Sometimes I say to people, can you sing while you're doing it? If you can sing while you're doing it, you're not holding your breath and straining. And then aerobic activities, we want you to exercise. Good for the heart, good for the head. Maybe avoid the most extreme things. So just a little bit of a control over your more competitive element. I sometimes say again, we want you to be able to walk and talk at the end of the bout of exercise that you've done. Can you walk away and talk to your friends rather than be carried away spluttering, which is what happens when I try to do too much exercise. So hopefully that gives you some insight. So yes, there are questions around exercise. That's the reason we want to do the study, and we want to understand those questions, both about how it relates to SCAD and how it impacts on recovery. But in the interim, we are comfortable and we think it is safe for patients with SCAD to exercise within those common sense limits.
Dave, could I ask a supplementary question that's come in prior to the event that's related to this? So often people are discharged from hospital with very little information about SCAD at all. Many are not referred for rehab. They often show up on the support page, and we have to say to them, actually, you should be referred for rehab. So often they might then be referred for rehab, but it's months down the line. So it would be really helpful if we could have some really common sense advice on what you should do as a newly diagnosed patient if you've not been referred for rehab yet. How can you start exercising? What should you do? What should you avoid? Bearing in mind some people used to run half marathons and some led very sedentary lives. So what general parameters can you provide for newly diagnosed SCADs?
Yeah, so the first thing is, to get on the rehab program if you can. And if you can't, or if people are saying, oh, we're worried about doing the rehab aspect because you're a SCAD patient, then ask your rehab team to get in contact with us. So as you know, for example, we're working with the colleagues in the University of Napier. We have exercise specialists on the team who can advise your rehab team about approaches to exercise. Immediately after SCAD, and that's not anybody in the room, but it might be somebody who's watching the video, immediately after SCAD, if your SCAD has been managed without stents, so it's been conservatively managed, remember that the bruise will still be there for a few days. And so initially, when you exercise, if you push yourself too hard, you may actually get true angina, where you get chest pain, which is exertional, okay? And not when you rest, but when you exercise. And so for the first few days, you do need to be careful. If you get that, you need to stop and rest and let the pain go away and just take it easy for a little bit. As hopefully you know, the healing aspects of SCAD start happening quite quickly. So that phase where you get true angina really only lasts for the first days to a week or two, and then will settle quite quickly. And then after that, it is about building up slowly. We want, first of all, you have to remember that an illness like this deconditions you. So you don't go straight back in at where you were before, because that's not going to end well. You have to start again at the baseline. We want you to warm up before you exercise and build up slowly. One of the pickles that a lot of patients with SCAD get, particularly those who get chest pain, is that you can get into this sort of pattern where you have a good day, do loads, get chest pain, feel rubbish, do nothing for a few days, have a good day, do loads, get chest pain, do nothing, and you can get into this sort of boxed pattern. What you're trying to get to is something that looks a little bit more like this. And sometimes what that means is doing a bit less on your good days but trying to do something on your bad days. So instead, when you have a good day, instead of kind of like, you know, running around after the children, clearing the house, doing the 10 jobs that you wanted to do, tone it down a little bit, but then on your bad days, still try to go around the block. And then that's the way, if you can just keep it going like that, that you can start to increment back to where you were. Okay, yeah.
So relating to that, I suffer really badly with fatigue.
Yeah.
Why? What is it? And
yeah.
Any advice? I'm yawning my head off now, and it's
I'm sorry.
It's not you.
Probably. You're not alone. I've been convincing myself for a number of years that it's all post-SCAD fatigue, and it's nothing to do with the content of my talks. Yeah, so I mean, there are a spectrum of symptoms that people get after SCAD, yes? Some of those symptoms, you know, fatigue, sometimes that can be related to the tablets. Sometimes it can be related to the actual injury to the heart in some patients. So sometimes there are a number of reasons why it happens that tend to be a little bit specific to the individual. And sometimes it can just be part of that post-SCAD pattern. So again, particularly if you've ever had something before, so for example, patients who have had pain problems before will be more vulnerable to get post-SCAD chest pain in my experience. Patients who've had fatigue problems before may be more vulnerable to getting fatigue problems afterwards. That's something that we definitely see, but it can happen anyway. It can just be part of that profile. And I think there are a few things. First of all, you have to give yourself a break. You know, this is part of recovery. This is often normal and expected. And so I think the trouble is that we all expect ourselves to bounce back to being everything that we were immediately the day before we had our SCAD really, really quickly. And actually, hearts take a bit of time to heal, heads take a bit of time to heal, and bodies as a whole take a bit of time to heal. I sometimes say to people, look, if you think about your day of your SCAD event, if you broke your leg that day, would you expect your leg to still feel completely normal now? Or would you expect it still to give you a bit of jip? Those of you who had your SCAD 20 years ago, probably that doesn't apply, but maybe. Those of you who had your SCAD a year ago, maybe you think about it in that way. Actually, you wouldn't be that surprised if your broken leg still gave you a bit of jip a year later. Hearts are no different. Just because they're on the inside, we think they should get better quick. But actually, they've got some healing to do, and we need to give them some time to do that. So I think it's part of a spectrum of expected. I think if you can try and do that, because again, fatigue tends to do that a lot. So you get good days, do everything, save the world. Get hit with fatigue, do nothing, sit on the sofa, feel awful, good day. So it's about trying to see whether you can do that. And I mean, I'm being a little bit flippant in some ways about it, but honestly, if you can do that, try and do a little bit less on your good days, a little bit more on your bad days, then what happens over time, you'll start to find that you get better and better. So on your bad days, just think a little bit about that, you know, can you just do a bit? Because actually, maybe that's all you can do right now. But if you can keep doing it and keep incrementing, maybe in a year, yeah?
I just asked, perhaps it's a question that other people might come about. When booking travel insurance, one of the questions that comes up, have you ever had chest pain? Do you get chest pain when you walk over such and such a distance? And then the automatic assumption is that it's angina. Would that be your technical definition of post-SCAD chest pain?
Yeah. So I'm going to talk about the answer to the question first, and then I'm going to add the insurance aspect afterwards, because they are different answers. Most post-SCAD chest pain is not anginal. Some will be in a small group of patients who still have problems with blood flow to the heart arteries, but that is uncommon in the SCAD population. Chest pain is very common. 60% of patients at first follow-up report chest pain after SCAD or something similar. It can be fatigue, it can be palpitations, can be a feeling of breathlessness. It's a little bit variable, it doesn't have to be chest, it can be here, maybe jaw, you know, different things, but 60% of patients report some symptoms like that. 40% of patients are getting those symptoms at least weekly. And in some of these patients it's intrusive, sometimes it can lead to hospital admissions. So these chest pains are common, but they are not anginal. Angina is a pain which comes because of a blood supply problem to the heart that is consistently exertional. So you don't have pain at rest, but when you exercise, you'll get to a certain distance and then you will get chest pain. And then you'll stop, you rest, maybe you use a spray, chest pain goes away, and then you start again and you walk and you get to the same distance, and lo and behold, the chest pain comes back again. That is what angina is. Most post-scan chest pain is not anginal because it's not a blood supply problem to the heart. We don't fully understand exactly what it is. We do know that in many people it gets better over time. In a lot of patients it's settled by 18 months to 2 years, but sometimes, as I say, it's a bit like the old war wound. So if you get a touch of COVID or a bit of emotional stress kicks off, something like that, it's that pain that you get when something like that happens. So it's common, it isn't anginal, and the response to angina medications is often not great for post-SCAD chest pain. But insurers basically raison d'etre, but insurers' raison d'etre is essentially to try and find a way not to pay out in the unlikely event that you happen to need them. By the way, it's very unlikely that you would, but in the unlikely event. So if you go away on holiday having written no chest pain, Dr. Adlam said no, and then you have a problem, and they go back to your medical record and go, says here, chest pain, we're not paying, right? So you have to just think a little bit differently from the insurance purpose. So from my perspective, from the insurance purpose, you tend to overcall things rather than undercall things, because that way you know that you're covered, and that's what insurance is for. It's for the reassurance that you will be covered when you need it in the unlikely event that you do, yeah? So, no and yes.
Just off the back of Jane's question about the fatigue and everything, when you were to have, if you were to have like a conventional heart attack as opposed to like a SCAD one, is the recovery time sort of different? Because like obviously like sometimes you talk to people and say, oh, so-and-so had a heart attack, he was back on his feet and doing this and this, and we're just not like that.
Yeah.
Is it fair to say
it is a different thing in SCAD patients? I think that is true. So, I'm a cardiologist, and, I've looked after lots and lots of patients who've had conventional heart attacks. My experience in SCAD patients is that the recovery is different. And that's one of the reasons for trying to do this, activity monitoring thing, to try and understand that in a little bit more detail. Yeah, so that we can understand that, we can document it, we can understand what post-SCAD chest pain is having an impact, what your fatigue is having an impact, maybe somebody's palpitations or breathlessness. We can get a better picture, because some of this is rather poorly described. So although you know it because you're experiencing it, and I see it in the clinic, we need to put that out there a little bit more, because then it helps in terms of rehab programs. People understand what the experience of SCAD patients is, and also hopefully with the work with the NIHR, how we can impact it in a favourable way to try and get over these barriers that SCAD patients experience, so that we can get you back to your best sooner, if that makes sense.
Would you call all the after effects, would you call that recovery, or would you call it that you've now got a condition?
Yeah, I see what you're saying. Yeah, I mean, we tend to call the chest pain kind of post-SCAD chest pain syndrome, but what medics do, they put syndrome on the end of a descriptive set of words that kind of, and then we kind of sound really wise about it. We kind of use it as a set of terms to describe the fact that we see this in patients commonly. Would I label it as something different? I don't think I would necessarily, essentially because I suppose what I'm trying to do is to view it in a positive way, to try to to say, first of all, this is real, because again, I think perhaps less these days, but sometimes in the past it was like, oh, this is just, you've just lost it because you've had SCAD, and, all of this isn't real, and you pull yourself together and all that kind of stuff. Well, it is real because we see it in, you're hearing it around you in the room. It's something that we see in clinic all the time, and I've said how many patients, nearly 6 out of 10 patients are getting this. So this is a very common phenomenon. So I think the first thing is, it's real. It tends to get better over time. It is quite variable, and sometimes I say to people it gets better over time, but it does this. And sometimes when you're down there, it doesn't feel like you've got better, but actually you are on an upward trajectory. I also think that it is important to have that, because we want you to get back to normal. We think you can get back to normal, but it might take a bit of time. Yeah.
Medication. Is medication for avoiding another incident or for recovering quicker?
So, we talked a little bit earlier about clinical trials, and there is a need for clinical trials in this space, and they have begun. So, again, information will gradually build over the coming years, but clinical trials in patients with SCAD will take some years to complete. So we don't expect the first clinical trials to report probably for another 3 or 4 years. And that will gradually build up over that time. So at the moment we base our decision making on observational data. The observational data is predominantly from a Canadian study, shows 2 things. The first is that control of blood pressure seems to be associated with a lower risk of recurrence. So if patients have a higher blood pressure, we're looking to make sure that that comes down. And the second is that the use of beta blockers, independently of their blood pressure effect, seem to be associated with a lower risk of recurrence. That is what we know right now. The observational data didn't show anything about hormones. The observational data didn't show anything about aspirin, but these are still unknowns, okay? But those are the things that seem to come out from the observational data. So what we are tending to try and do in the clinic, primarily, is make sure that your blood pressure is well controlled. And if you are able to tolerate a beta blocker, we are trying to keep you going on a little bit of beta blocker. Now, not everybody can tolerate beta blocker. Some people get very profound fatigue and symptoms associated with it. Some people's resting heart rate, blood pressure is too low to have a beta blocker. So this is not for everybody. And in terms of the aspirin, the antiplatelet drugs and things like that, again, there will be some patients who have stents. It's a different situation there. You need to have at least one medication to support your stent in that situation. Again, a very few people will have bypass grafts, and those patients will be managed slightly differently in terms of their tablets. So it is a little bit different from patient to patient, but hopefully that gives you a little bit of a perspective as to where we're coming from with the data, yeah? So again, some patients will have more in the way of a heart injury, a little bit of a bigger scar, maybe the function's not quite as good. Those patients will tend to be on a little bit more medication to support them, whereas somebody who's got a small injury or no injury on their heart maybe needs a little bit of a less injury. So hopefully that gives you a little perspective, but it is quite individual. And that's one of the reasons that obviously, lots of patients will come to one of the different clinics so that we can sit and have a think about you and work out what your tablets should look like.
Okay, this one's a little bit controversial potentially.
Well,
do it yourself troponin blood tests.
Yeah.
So every few months on the support page, somebody recently diagnosed will say, oh, wouldn't it be amazing if we could have a skin prick test that we could do at home that would tell us if this, am I or am I not having another SCAD? If I could test myself at home, or if I could go to my GP or my chemist rather than sitting for 6 hours in A&E, could I do it myself? My worry is that if they're not in a place of safety and they get a positive result from such a test, what would happen? And would the test be accurate enough? Yeah. Have there been any trials? I think there may have been 1 or 2 trials. 1 or 2 ambulance trusts may have tried in-ambulance skin prick tests or some kind of testing. So what's the latest information? What can you tell us? And what should people do if they think they're having another SCAD?
Okay. This is an area of interest. It's something we've thought about. Something we've had a few initial discussions with some international partners to think about. So it is not off the cards. Obviously, what we have to try and do here is we have to try and make sure that if we go down that route, first of all, it's got to be affordable. So, we have to have a system that, if the test is kind of vastly expensive or whatever it is, and, that shelf life is 10 minutes, then that's no use. But also, we have to make sure that it's a safe thing, because one of the things that we recognise, obviously, with patients who have very typical symptoms, is that, you know, we actually want patients who are, you know, having those symptoms to be in a place of safety, so to go to hospital to be in a safe place. So we have to try and think carefully about that, because we don't want people to be sitting at home with very typical symptoms waiting for a troponin test that's not going to come for another few hours, when actually we would like them to be in a place of safety at that time point, yeah? So, but we also recognise that those kind of tests may help patients who have post-SCAD chest pain to provide reassurance to safe hospital admissions. So it's a complicated area. It's something that we are thinking about. We don't have active plans for research in that area at the moment. And I think we would certainly have to think very, very carefully to make sure that if we were to go down that road, that we had some very careful guidelines and approaches to make sure that it was entirely safe. Because safety is the most important thing. And at the moment, you know, I guess, at least with the advice, we're hoping that that keeps you safe.
So if somebody is worried that they're having another SCAD, would you mind just for the record saying what they should do?
Yeah, so if you are, so the first thing to say is that generally speaking, people that have a recurrence, and first of all, we should say that recurrences are not very common, right? So there's a 10% risk over a 5 to 10 year follow-up period, according to the Canadian prospective study, so something like that, so 1 to 2% risk per year. So this is not something to be sitting waiting for, okay? You're 9 times more likely over that time frame not to have a problem than to have a problem. So it has to be put in perspective. I sometimes say it has to go in the little box at the back of your brain that says, open this box if I have very typical symptoms, but not to dominate the front of your brain, which should be about having a good life and enjoying yourself right now. But if you have that thing where you go, do you know what? This is the something that I need to go to hospital for, then, you know, follow your body's advice, go to a place of safety. Maybe you get it wrong. Fine. If that's the case, it's a learning experience. If your troponin is negative, then you know that that set of symptoms was something that you could be a little bit cooler about if it happens like that in a very similar way again. But ultimately, you know that that is a safe process. So if you go to hospital, get a troponin checked, and obviously if your troponin is positive, then the doctors and the team in your hospital will look after you accordingly. Always a good idea if you've got a letter from your clinic, something like that, take it with you, show the ambulance guys so that they know roughly where you're coming from, and it just helps to speed things along. Yeah, go for it.
After you've had a SCAD, do you ever heal to a point where it's just the same as if you'd never had one? Or do you always have to exercise, you know, the level of caution that...
Yeah, no, so SCAD, remember, is a bruise. It's kind of picture at the bottom there. Sometimes that bruise can develop into a tear, but primarily it's a bruise. And like all bruises in your body, it heals over time. So the artery will go back to normal over time. And so we know, because we used to take patients back to the cath lab and do a repeat angiogram. And when we looked at those angiograms, those arteries would look normal if we were to look, you know, 4-6 months down the line, or even earlier often. So the artery heals. Sometimes you're left with a scar on the heart. That is something that varies from patient to patient, but in SCAD patients, those scars are often very small. So in the MRI study that we did in all of our SCAD patients here, 40% of patients had no measurable scar on those MRI scans, and a lot of other patients had very small scars. Obviously, 1 or 2, unfortunately, had bigger scars, and we need to think about that with the tablets and medications and support and things like that. But much more commonly, the heart is in really good shape. So actually, yes, often in terms of what the heart does, which is a pump, it's nothing to do with romance, sadly. It's a pump. In terms of what it does as a pump, most of your hearts will be pretty much the same now as they were the day before you had your SCAD. Maybe with a small scar. I think I was talking to somebody earlier, I was saying that I have a small washing up injury on my thumb, a little scar here. It's a good reason not to wash up anymore, because of the vulnerability of... But my point is that my thumb still works, right? Yeah? So yeah, it has a scar, but it still waves and wiggles and can do whatever it likes. And it's the same with many of your hearts. Yeah, you might have a little scar there somewhere, and we look on the MRI scan, we can see that. We may alter your tablets accordingly. But in terms of does your heart work, yeah, it works just the same as my thumb. Well, hopefully it does a different job to my thumb. But you get the idea. Yeah?
As someone that's had coronary artery spasms for a majority of my life, does that make me more prone? I've had a SCAD too. Does that make me more prone to SCADs? Is there any data that shows those two are linked? Is there anything there?
So very little data. All that is known, I think, is that there are some medications which are used in testing for coronary vasospasm. And if you look at the studies where those tests are used, a very small number of patients who have pharmacologically, so drug-provoked spasm, have SCAD as a consequence of the drug-provoked spasm. So how that fits with kind of, standard chest pains in that scenario, I'm not so sure. I have to say it's not a common scenario that I see, which maybe hints to me that those things are not related rather than related.
With the latest sort of SCAD news that you shared with us on the candidate genes, their impact potentially on collagen and connective tissue, another topic that comes up on the support page a lot is, should I be taking supplements such as collagen, magnesium? Those are the two that come up most commonly. We tend to go down the route of saying, you should check before you start taking anything that it doesn't contraindicate anything you're already taken. But if there's any other information that you'd like to share, that would be really helpful.
Supplements. So, if we come back to our clinical trials thing and our observational data thing, in terms of my views about what to take, what not to take and things like that, they are largely based around things that you can show do something positive, rather than things that are rumoured to do something positive, yes? So until somebody does a randomised clinical trial of collagen in SCAD patients and shows that it does something, for me, take the money that you would spend on your collagen supplements, your magnesium supplements, pop it in a jar, and when the jar has accumulated, have a nice night out, spa break, which will be a boost to your emotional stress levels, which probably will have a positive impact on your overall SCAD risk.
Since I had my SCAD, I've had real problems in my shoulder. And from what I've read about FMD and things, some of the things indicate you would worry about necks. And would I be all right to see a chiropractor, have a massage? Would you?
Yeah, okay. So the first thing is as you know, we generally recommend the head to hip scan just to make sure that all the arteries in the head and neck and so on and so forth are, that they look okay and that there's no issues. And that would be a sensible thing to do before embarking upon anything to do with the neck. In terms of the whole kind of chiropractic stuff, there is a little bit of essentially kind of single case type reports of neck dissections occurring in people that are having kind of, more extreme kind of neck position type chiropractic. There's one or two. So the other thing we sometimes get asked is the roller coaster, the sort of sudden head neck flexion extension thing. Again, one or two cases. Not like case reports in the world that you see of these things. It's not like people are piling out of Alton Towers straight into my clinic with it. It's not how we see it, and it's not that I see dozens of people kind of directly immediately after their chiropractic appointments coming to the clinic either. So it's likely that these things are not a high risk, but they have been reported, and so it makes sense to err a little bit on the side of caution in terms of the more extreme neck positions and those sudden movements of the neck. In terms of massage, it's generally about muscles and not necks. So if somebody is massaging you here, then you need to get them arrested pretty quickly. Whereas at the back of your neck, these thicker muscles at the back here and across your shoulders, maybe that's reasonable. But it's the arteries run up the front here, so leave those fellas alone because you need them for your brain. Yeah.
So a lot of SCAD patients also have migraines.
Yes.
And I know from your FACT-R1 research results that we found that SCAD, migraine and FMD often are associated. Obviously there are millions of people who have migraines who don't have SCAD and FMD. But recently there's been talk about a new migraine medication, commonly referred to as Gepants or CGRP. I know that a lot of SCAD patients who used to take Triptans are advised not to take them. Do you see this new drug as potentially being of use and interest to SCAD patients? And I do know a SCAD patient who is trying to access it, and even though it's been approved by NICE, it's almost impossible to access.
Yeah. These things take time in the NHS, but as you say, they are NICE approved. So the first thing to say is, yes, migraine very common in SCAD patients. There's genetic overlap between those common genes we talked about before for SCAD and the genes for migraine, so we see this quite commonly. Treatment strategy is, there's a bit of a question mark over Triptans. It's a kind of slightly similar question mark to what we were talking about a little bit earlier on, which is that, there are some case reports, a few studies out there of patients, the odd patient who has had SCAD shortly after taking a Triptan or having other dissections. Now, of course, we have to remember there's a heck of a lot of people out there on Triptans, and it may just be that that's coincidence rather than it caused the dissection. We don't know that with certainty, but it raises a question mark, and that is a question mark which, in most people, what we're trying to do is to minimize Triptan use, stop Triptan use if we can because of that concern. So the first thing is, are there alternatives that work? Can we get simple pain-killing medications, anti-sickness medications, things like that help for migraine. The second thing is, can we improve the prophylaxis medications? So, for example, the beta blockers that we like in SCAD because of the observational data that we were talking about when we answered Scott's questions a little bit earlier on. Beta blockers are also quite an effective migraine prophylaxis. So again, it's not uncommon for patients to say, I had terrible migraine all my life until I had my SCAD, and it's been remarkably better ever since then. And the reason for that is because they've been prescribed beta blockers, and beta blockers are a prophylaxis for migraine. There are also a bunch of other prophylactic agents for migraine. I'm not going to go through each one and their pros and cons here because you would all fall off your chairs at some point before I completed my migraine description, but there are a lot of other things that can be tried. And so the main thing is to engage with your GP, maybe a migraine specialist if it's a particular problem for you, to talk about what other options might help to reduce your migraine frequency. These new medications look very promising, both as an alternative to Triptans, also potentially as a prophylactic agent for those people for whom other prophylactic agents have been exhausted. So I think that they are definitely something that we will be keen to explore further in a lot of SCAD patients. So it's something to, again, talk about, think about, keep your eyes and ears open. I think they will be rolled out over time. Usually what happens with these new medications is that they will be in very specific groups of patients, and once we find out what those rules are, we can see whether SCAD patients fall into those categories. But the Triptan alternative is particularly focused on patients in whom Triptans are a concern, and SCAD patients would, in my view, fall into that category. So I think it's a sort of, watch this space answer from the migraine perspective, but certainly there's some hope that there may be some new options, and migraine, very, very frequent question in SCAD patients. Yes, sorry. It was such a small hand and that I didn't notice it. Yeah.
What's the latest research and guidance for people who've had a SCAD that are looking to get pregnant?
Yeah. I think the first thing to say about pregnancy after SCAD is that the views are very individualized. It's very specific to a particular patient because it depends on things like heart function. It depends on what medications you are on. There are lots of different things to think about to weigh up those risks. What we know from two studies, one by our friends at the Mayo Clinic and one that we run in Europe, is that small recurrence risk that we've talked about before for SCAD patients does apply during a subsequent pregnancy and postpartum period. When the guys at the Mayo Clinic looked at it, it didn't seem that the frequency was particularly higher in patients who were pregnant than not, but there was still that risk. So that 10% risk over that period of time. So in a pregnancy and within a year postpartum, maybe somewhere about 7 or 8% risk of recurrence occurring during that period. And we know that SCAD can be a more severe presentation when it happens in pregnancy. So that risk cannot be mitigated. So there's no medication that we know of at the moment with certainty that can take that risk away. Of course, the risk of very serious things happening as a consequence of that will be very much smaller than that still. And so then it is an individualized decision about, first of all, whether you want to take that risk, and also whether there are any other considerations from the perspective of medications, heart function and so on that need to be weighed up as part of that decision. So pregnancy after SCAD is not banned in most patients. There will be a very small number who have particular issues with heart function, maybe where we would recommend against, but that will be uncommon. In most patients, it's about thinking carefully about you and what your specific risk is and what the specific issues are with your medications, and then thinking about whether or not that the risk that we know about, that's there, is a risk that you want to take. But I think what I would say is, for SCAD patients who are contemplating pregnancy, it's very important to get advice before conception. So before you become pregnant, when you're thinking about getting pregnant, talk to your cardiologist or talk to the SCAD team, and we can either give advice ourselves or refer you onto the local pregnancy heart team who will look after patients who have potentially contemplating higher risk pregnancies. So talk to us, get advice, and it will be an individualized bit of advice when it finally comes. But hopefully that gives a bit of information, yeah? Yeah, go for it.
A lot of people who have SCAD also have FMD. Is there any new research about the correlation between FMD?
FMD and SCAD, yeah. So, I mean, FMD is, so just to explain what FMD is, first of all, FMD in the context of SCAD is an abnormality of what the artery looks like on an image. And it looks like a string of beads with sequential dilation and narrowing. It looks kind of irregular, essentially, right? That appearance is frequently found in SCAD patients. About half of patients, if you look hard enough, will have some of that kind of FMD somewhere. In our experience, FMD in SCAD patients is pretty benign. It's frequently found, but causes very few problems. We don't usually find any particular issues in terms of problems with the arteries or artery events afterwards. Sometimes, yes, a bit of pulsatile tenosis if there's a lot of head and neck FMD, but very rarely do people get problems related to it. In contrast, incidentally, to people who present first with their FMD. So primary FMD, a few of those patients will go on to have SCAD, but often the FMD, because they've presented with it as their primary thing, is more of an issue than in patients who have SCAD and FMD. When we're doing the head-to-hip scan, we will often find FMD, and the main message from me about that is that I'm usually pretty not worried about it. You know, it's almost like a marker of patients that have SCAD rather than something that we need to do anything about or watch or anything else. We're really looking for those little swellings of the arteries, which we call aneurysms, or sometimes dissections of the arteries, and sometimes those dissections can be asymptomatic, so you can not know about them. And those things, sometimes we might need to keep an eye on over time with serial scanning. Sometimes it might affect your treatment, so we were talking earlier. So again, if you have a lot of FMD in your head and neck or a dissection somewhere else, we might be more inclined to advise you to continue with aspirin or clopidogrel or one of those type of medications. So it has an impact. We're obviously also interested in the intersectionality between SCAD and FMD. We understand that the genetics of these conditions overlap, but it does seem that they are not the same. And so, you know, there probably is an interrelationship, rather like there is with SCAD and migraine, rather than that, you know, SCAD is a manifestation of FMD, which is something that you sometimes hear people talk about. So, as with a lot of things with SCAD, more things to learn, but, you know, we know a bit more than we did. Yes?
As someone who hasn't suffered from a SCAD but has a mum who has, who also enjoys a very busy, active lifestyle, what can I do to emotionally support her, but also remind her on her good days that she doesn't have to save the world?
Yeah, so, I mean, it sounds like you're all probably already doing all the right things. I think perhaps a really important message with SCAD is to take a step back from all of the stuff that we've been talking about and to remember that this is a condition that has a very good prognosis. People with SCAD do very well. Yes, small risk of recurrence, we have to handle that. But even with that, People with SCAD do very well. Generally, it causes small injuries to the heart, as we were saying earlier. Even in recurrence patients, the cumulative damage to the heart is often too small to be causing problems in terms of heart function and performance. So actually, the overall messages with SCAD are pretty good. Now, maybe that's not the message you want to give if you want to kind of stop your mum from being crazy. But I think it is overall, it's a positive message, right? Yeah, go for it.
SCAD patients and FMD, would any considerations need to be made, like with where to travel, apart from the insurance going through the roof? Are there any connections with hotter temperatures, high humidity, or if you're going somewhere with a high elevation?
Yeah, so not as far as is known. So I don't have any, again, problems with flying, for example. Long haul flights, those kind of things. Again, I'm not seeing busloads of patients having SCAD being shipped from Heathrow directly to the clinic for recommendations. Just don't see it. So presumably that means that flights are not a particularly high risk thing. I have had the question recently about somebody who wanted to trek at high altitude. And my answer to that question was this: first of all, it's not banned. We have to remember that if you are at high altitude in a place that's remote, that in the unlikely event that it just happened, that 1 to 2% per year happened in that unit, it's a very low risk. It's probably a 0.00 something % risk. But if it was to happen at that point, then it could be tricky for people to get you to a place of safety. And also we have to recognize that not many SCAD patients are, at Everest Base Camp. And therefore, we don't have any data or any real information from that kind of, if you like, more extreme type of activity to be able to give secure advice. So I can give secure advice because I'm on the flying side of things, because I know that lots of SCAD patients have been flying and that we just don't see that in the clinic. But of course, those like very high altitude kind of activities are very difficult to comment about because they would be unusual activities in the community, and therefore it's very difficult to say with certainty that a patient with SCAD is safe or unsafe to do that. That's just a no information type of answer, right? And I suspect the person who raised that particular question is going to do it anyway, so we'll then have an N of 1 to answer the question next time. But yeah, so I think I have to be careful about giving a kind of it's safe to do anything answer to the question, because some of those things we just, realistically, we just don't know in this population. Yes?
If you've got hypermobility as well and want to exercise, do you need to be careful? Because I don't have a full understanding of the FMD. Does it make your arteries likely to rupture or anything?
Yeah, so...
Can you... obviously, I easily overstretch. So I'm trying to control that.
So do you need to worry about it? I think you don't. So again, in terms of the published data, we followed up a bunch of SCAD patients over time who had FMD and didn't have FMD and looked to see what happened to them. And basically, vascular events, things that are happening away from the heart, were incredibly rare. So again, I don't think it's something that we need to wrap you up in cotton wool or whatever it is to protect you from. I think you are, from what we can say, you are safe to do things that are within those kind of exercise limits that we talked about a little bit earlier on.
So I have got one more, sorry.
Go on then.
It's the group comes up with the questions. Fasting, whether for religious reasons or it's very popular at the moment for general health, the intermittent fasting.
Yeah.
The comments we usually make on the page are that you've got to be careful with dehydration, particularly if your blood pressure is low or low because you're on beta blockers. Any other comments about any dangers of fasting while recovering from SCAD?
So no, basically. Again, you'll have gathered that my kind of metric for things like this kind of question is, do I see it? We probably will see nearly 500 referrals for SCAD in the clinics this year. Do I see patients coming in, during the fast with problems any more than at different times of year? And I just don't see it. So, I think the guidance makes a lot of sense, but I guess that guidance would be similar anyway, to be hydrated during the fast. but I don't feel that it's a particular issue. I guess there's always going to be those variations around that in terms of patients who have, are on a lot of medication for reasons or have more impairment of heart function, where you might want to think about it or get individualized advice about whether or not it's safe to fast. But there are no particular SCAD specific things that I would be worried about from that perspective. Thank you very much for listening. I think even the knight in shining armour has fallen asleep under his helmet. So we had better stop now. These are some things for my very excellent team who deserve more than I can give them. So this is just a thank you to my team, basically, so they know they're amazing, and they are. Okay, I'll hand over to you guys.
Yeah, I'm only just going to say thank you to everybody, really, and obviously thank you to the We're really lucky to have you, leading so much research and just having such a wonderful team. I really do appreciate everything you do. I know we say it each time, give up your weekends for our conferences and these events, and it means so much to everybody to have the chance to meet you and to meet each other, and just, these events are so important, and they're just, we love doing them, and they're such a great day. So
thank you. So anybody who wants a joust on Bosworth Field before they go.
And thank all of you for coming. It's been a really wonderful day. Thank you very much. So we've got the team filming again. We've got Sophie, Ed and Ian doing photography. These are just really brilliant. Met them a couple of years ago, and they've been doing our events. And
we have stand with that mic on a pole like that. Must have arm muscles.
Strongest arm in the world. And obviously just to the trustees, to Sarah, to Debbie, former trustees, Karen, Harriet, it's nice to have the team back together for the day. Karen and Clyde for, planning for the walk and leading the walk today and everything. So, it's always such a lovely community spirit, and, we really enjoy these events. So we hope to see you again at another one, and safe travels home. Thank you.
Great.